Thanks, Peter. And Fiona, if you may come up. Thanks so much for this overview of the complexities, the intricacies, the beliefs, the low-value care. I mean, there's so much low-value care that we're faced with every day. And we would have a lot of questions in the next few minutes, but let me maybe ask the two of you. In our clinical setting, what oftentimes happens, there's doctors in the rooms, there's physios, there's that athlete that has been suffering from recurrent back pain and now is ready to talk about it or to come and seek help. And it's an emergency. And you don't even have 20 minutes. You've tried to squeeze the athlete in between two others. And how do you approach it? Because we understand time, constraints and all that. What do you do in that first encounter when they come with the pain to not lose them, to not have them go search for an MRI somewhere else?
Yeah, I reckon that's a tough gig. Look, I think setting the agenda is really important at the beginning to go, tell me what your primary concern is today. You know, what is your main concern? So if they're like, I think I've really broken my back, it's like, okay, tell me your story, what's your history, and then screen for serious pathology. I think that's the most important thing if that's the patient's concern. Now, if the person's in pain and distress, then you need to, if you only have 20 minutes, you've got to revisit them very quickly to make sure you can take them on that journey. But if they think they're broken and you deny them of a scan, then they'll go shopping. We know that. And so that comes back to our confidence and trustworthiness as a clinician, that you have to build that really quickly. But I do think fundamentally, I mean, I spend an hour with every new patient, which is unusual, right? But I see people like Matt in my clinic, and I think the biggest thing I hear is that their agendas aren't dealt with. You know, their concerns have not even been asked. So that's something where we can start to go, what are your main concerns? Let's address them in that first session and then map a pathway for you.
Do you think there's room for having them prepare the encounter?
I do.
And how would you ask them to prepare for those 20 minutes?
Great idea. So before we see anyone in our clinic, they fill out the Honour screening tool. It's nice, which is a really helpful screening tool, and it identifies people at risk right at the beginning. So if you're rated over 50 on that screening tool, it flags mood, depression, sleep, beliefs, and it gives you a snapshot right away. We also screen for red flags in it, so it saves you time. And we also get a health history, and we ask them about their short-term and long-term goals. And so you can know what their concerns and agenda are before you even see them. It saves so much time.
Thanks. Let me throw the ball over to you, Fiona. You have now that rower who comes in with pain, and you're a rower, right? And you know how they respond to this. What is your first approach with that pain that is now limiting them to row? There's competitions coming up, there's pressure and all that, and you have that limited time encounter.
We were discussing this before, and you have a window of opportunity there. So that encounter can stop becoming persisting, disabling, maybe. If not, at least you can do something. So I think one of the most important things is to validate them. Not diagnostic label, not I'll take over from here. It's like any psychologist would tell you, let them speak, let them tell you what their personal experience is, and validate that. So I heard this must be very difficult for you, and I think you've already gotten in at that point. So they will then trust you, and you might be the first person to do that, because we're quite patriarchal with athletes. Like I said, they're commodified. You're part of a system. You now have a label, and you are now in a process. So you are now, what we should do, in the driving seat. I'm going to coach you here. I'm going to support you, but you are going to help yourself. That would be very much my approach. And I don't get an hour, actually. I get half an hour. But if I spend that half an hour asking them what their experience has been, how do they feel about it, what do they think is going to happen, what are their stresses, I can do much more with that conversation, where I might not even look at them moving, or I might do a very cursory in that half an hour of experience, than even with an hour and a half, where I do all these movement tests and things. And I don't think we do that enough, really. We might have our carbon-plated, this is the list of things we do, and I think we're very good at doing that as a physio, or we can do too much of that. But I think we maybe need to think a bit more like psychologists, because we might be the only psychology people that they see, people who will listen to them and understand their experience.
Thank you. Anita, on Slido, we have a few questions.
I start with the first one. Not sure to understand, is there any difference in management of non-specific low back pain in athletes that with common people, than with common people?
Yeah, I think we both touched on that, actually. So they're all just people with different goals and different expectations, different social stresses. And I think just understanding that context is really important. You know, if you've got someone like, you know, I work with a number of athletes, they have different pressures. Understanding them is key. So there are unique pressures and obviously physical demands in athletes that are different to people without pain. But we know the drivers look the same, whether you're an athlete or not. And I think that's the key thing, is they're not different in one sense. We just got different factors that underpin the processes.
Yeah, I think in any job now you can't sack people because they have back pain. You have to keep them working for you and you find a different role. You can with an athlete. If an athlete is injured, you can throw them on the scrap heap, and they know that, and that's in their head, and that's where the culture of secrecy comes. And I think if you can think about that and you know that that's how they feel and that's what they know, and they're also worried you'll tell the coach as well. No matter how much they think they should trust you, they'll still probably come in with an idea that you're going to tell someone what they're telling you. So I think that's useful when you speak to them, say, this is going to be, nobody's going to hear anything about what you tell me, and it's important you do tell me how you feel because it'll help me best manage you. Now, if you're really lucky, you're in a system where you have coaches that support that. I've been in both. It's really hard when you have a coach who does commodify them and doesn't trust you, and the athletes will pick that up really quickly. And it is very difficult. You do have to understand that they will be taken out of the team if they can't perform. And I think you need that in your package of how you discuss it with them as well.
Thank you.
Fiona, you showed us some data on prevalence, like 50% on the 12 months of back pain in athletes, 36% in youth athletes. One thing that we see oftentimes in sports is that they're tired, okay? And youth athletes and all that, which is normal, actually. If they're not tired, they're not really training. So it's part of being an athlete. Would you consider back pain is part of being an athlete and should be somewhat normalized, or how would you approach that?
Yeah, I think that data is really useful. And I think it's a bit like headache. It's a normal human experience. And it is also a response to load. So I certainly know with our rowers, and I know myself, you do a big training session, you get out the boat, you can hardly straighten up. That is a response to load. It's not an episode of back pain. And I think especially one of the things we're trying to do with our juniors is work out what that is. Tell their coach how they feel. After my weekend training session, my back was hurting, but we go, did it go more than 24 hours? Then that's a biomarker. So let's do something about that. Let's deload you a little bit. So I think one of the things we tried to do with the rowing is look at that, where does in the human anatomy do you respond to loading most in your sport? So if it's your back, then we can actually put things in the system where we can say it's normal to feel like that with loading, but maybe we need to mitigate with some certain behavior. So that can be pain persisting, that kind of thing.
Okay, do you want to take one more?
Well, we have two similar questions to Peter. They ask about the screening tool name / questionnaire.
So OREBRO, Oribro. It was a screening questionnaire developed by a pain psychologist, Stephen Linton, who's based in Sweden. And he's done a lot of work around predictors of not working. And I would say they're pretty consistent across, maybe not engaging with sport, but I don't know if there's been much work. That's just a really useful 10-item screening tool. And you can Google it online. It's free access.
Perfect. Yep. Thank you very much.
Amazing. Thank you very much.
You need to.
Sorry, I think
you need to listen to your wife more.
Yeah. I think this will conclude our session, and a big applause to Fiona and Peter.
Thank you very much.
Thank you. We would have a zillion questions, but I'm sure people will come up to you. We're heading into the break. Have a nice coffee and chats. And at 12, we're back for the next session, and I'll go get that MRI.